I think it's time for us to go to the panel. Many of the questions will be addressed at that time too. Our panel members are shown here. It includes Dr. Patrizia Farci, who's with NIAID, in charge of the section on hepatic pathogenesis. Dr. Paul or Skip Hayashi, who's now at the FDA, formerly at the University of North Carolina, is also one of our active members of other networks, including the Dillon Network. And Dr. Brian McMahon, who's at the Alaska Native Tribal Health Consortium and who's done so much in demonstrating the efficacy and usefulness of hepatitis B vaccination. You can point out that while we're still having acute hepatitis B in the lower 48, Alaska has really the record of having a very high baseline level of hepatitis B that has decreased to very low, right, Brian?
That's correct.
Yes. So these are our panel members, and I'd like to first solicit questions from them that you have about any of these or comments. Patrizia?
Yes. Okay. Thanks, Jay. And I have a question just for Nora. You did a terrific presentation, and you really presented very important data, especially in line with the current trend to shift from a long-term or even lifelong treatment to a finite course. However, you showed that there was no significant increase in HBsAg clearance, and some develop severe flares that require the introduction of nucleoside analogs. So my first question for you, based on your experience, is, do you think that in clinical practice, outside the clinical trials, it is prudent to adopt this strategy, considering that the risk of a severe flare that sometimes is even higher than the benefit, especially in patients that are e-antigen negative chronic hepatitis B? So in other words, I mean, if in Italy, in other country, chronic hepatitis B is characterized 90% by antigen negative chronic hepatitis B, and in 30% of patients with cirrhosis. So my question is, can you please comment on the generalizability of your finding, considering that your study, most of the population were from Asian, and also I was very, I think one of your most striking findings that the genotype A2 response to therapy is only for e-antigen, not for e-antigen negative. So this is a very striking, I think we needed to do a lot of study to see if there are any difference. But in any case, your data are very important. I'm sure that open a lot of debate about also the extension of the study to all the other countries where chronic hepatitis B is mostly e-antigen negative.
So I would highlight that, you know, this is one of the few prospective studies, and I think that that's why it's an important study. And we had this very nice equal representation of e-antigen positive and negative, allowing us to really see differences there that really aren't apparent in other studies where they start with people who've been on nukes for a long time, and then they're all e-antigen negative and they withdraw. So I think you're right, bring different information forward for practitioners. I think that what we show is overall this strategy results in a very low rate of surface antigen loss and requires an intensive degree of follow-up, right? And with some potential risk for flares. So I personally think the balance isn't right to make this prime time yet. Right? So this isn't something we should say everyone should do, because the benefit, that surface antigen loss, is quite modest. And we still, I think, requires an intensive follow-up, and then there's still some risk. But, you know, we all know that there are some patients who are very keen to come off treatment. And then I think it's a matter of, you know, having that very detailed discussion. The good news is there are other studies kind of helping to identify other predictors. So we also show that if you're e-antigen positive, that maybe that's a better scenario. We show that the level of surface antigen makes a difference. So there are other aspects that can come into play in making an individual patient decision. But in terms of like a guidance around we should withdraw everyone, I think our study would say that that's not a strategy that should be adopted. And I have my colleagues here, so I'm sure Anna and they'll probably have different ideas. Yeah.
I want to point out that genotype D, which is common in Italy,
yeah.
there were no responders, right? Basically, no S loss. Anna, do you want to comment?
Yeah, only 1 out of 87 patients was very striking that lose HBsAg. I mean, that was really also compared to other studies that have been published where keeping tenofovir for many years, you have at least 8-10% of patients that clear HBsAg. I don't know whether, so this comes the variability and the heterogeneity of the patients in clinical trial, but I think your data are very, very important also about the role of the quantitative HBsAg in following the patients. Very important data, Nora.
Well, I think that a very important point is hepatitis B is not a homogeneous disease. And sometimes when you read other people's results, it doesn't necessarily mean that you can just apply it to your patients. You have to look at the patient populations from which the data was derived and your own patient. I mean, Nora showed very clearly that, the approach of taking use of therapy for the Asian patients is not going to be beneficial, or very rarely beneficial. And this is also true in other studies where they have compared Caucasians and Asians and show a major difference. So the genotype D, I mean, I think it's because the German studies and Italian studies, they were all e antigen negative. I think the reason why we could find genotype A2 is because we included half of the patients with e antigen positive at the start of treatment. If it were all e antigen negative at the start, maybe we won't be able to show this.
So the question is, why does genotype A2 not able to evolve into an E negative chronic hepatitis B? That's kind of what we're seeing here.
Well, I think in part is related to the epsilon and the pre-call mutation, the C1858 and the G1896, whether you break that CG bonding or not. So that's really related to that. And HBRN also published a study. Daryl was involved in that pre-call call promoter mutation study, where we did find some patients with genotype A that were able to select for the pre-call stop codon mutation, but then they had a change at the 1858 position that allowed them to have that stop codon mutation.
Right. So we don't really know why the A2s respond better, but this issue of their lack of ability to create the pre-core mutant may account for why they cleared S so quickly. Other comments? I have questions for you, Will, about the delayed clearance of HBV DNA. Is that a predictor of chronicity of acute hepatitis B?
No. I think these late clearances, and again, we were looking at S antigen. There, of course, there's data on DNA, but we didn't specifically look at exact timing of HBV DNA clearance versus S antigen. But they were typically close together. But I don't have specific data on that. But I think I think this is just real life, that our earlier definition was perhaps a limited one. I don't know why. Otherwise, it would have changed over the decades. But there's no evidence that the longer duration patients developed bad disease. I think they typically had very low enzymes and just seemed to have persistence of S. And it was a reason for keeping people in the clinic and having them come back and come back and come back, because again, we wanted to see S clearance, which I always follow my patients to have S clearance if at all possible, if you can keep them on board.
Well, it's well known that patients who develop chronic hepatitis B typically have mild or minimal acute disease. It's
Right.
usually asymptomatic. They become the ones with symptomatic acute hepatitis B. The vast majority will eventually clear.
Absolutely.
So treatment throws a ringer in that, doesn't it? Now, Brian, I have a question here about, let's say they say this investigator says that they have young patients who were vaccinated at birth who are surface antigen positive when she sees them. Have you seen this at all, breakthroughs?
Yeah, we actually have seen a couple of patients that were vaccinated. And there was no follow-up to determine whether they actually responded or not. One patient was vaccinated right at birth, and then and his mother was surface antigen positive. We don't know what her titer was at the time. He got 4 doses of vaccine with the 4th dose at year 1, and he developed hepatocellular carcinoma at age 28, was HBsAg positive.
Nice.
So there are failures that do occur, and with the birth dose vaccination, the failure rate can be as high as 10%. And so that's why I think the recommendations of using both HBIG and antiviral therapy at a certain cutoff of HBV DNA are really important. And the other thing I think that's been shown in our studies and also other studies is that it's the younger people, when they get infected under the age of 5, that have the highest rate of HBsAg carriage, about 30%, if they have not been infected by their mothers. So it's really important to get the vaccination series starting at birth and completing that. Unfortunately, we don't have the resources to test everyone that gets vaccinated or follow everyone that gets vaccinated in the US, but we need to follow the pregnant. We need to test the women who are and find out who's HBsAg positive and test their viral load and make the decisions about what we're going to do for the offspring, for the baby at that point.
So perhaps, Nora, you can address the issue of the antigen positive mother with high levels of virus, where this is probably occurring, this breakthrough and failure of vaccination.
Yes, well, that has been established, that the high level of viremia, which in these moms can be a risk factor, especially in countries where they're using vaccine alone and not vaccine plus HBIG, and that there can be a vaccine failure rate as high as 10%, which is why we've now, even WHO is now recommending that women with viral loads over 200,000 should be on antiviral therapy in the 3rd trimester to try to reduce that risk, and has been shown to be effective in terms of a strategy. So
there's an issue of flares during treatment, and now we have Skip Hayashi here from the FDA, and this is a real problem in treating liver disease, is how to interpret flares. Is it due to drug-induced liver injury, for instance? Or is it, in this situation, it looks like it's a part of the disease. It may be actually beneficial.
Right. So, thank you for that. But I had a question for Nora too, but I'll answer yours, Jay. I think that is true. But the nice thing about the HPV trials is, the ones at least I've been brought in on, you have good data. You get DNA data, you get serologic data. And generally speaking, we can tease that out and adjudicate those cases and say, no, this looks like a flare of the virus, or no, maybe this is symphilia. I think the bigger challenge is, when we screen the whole study, we've been using EDISH for years, and it just doesn't work when your baselines are all over the place. And that's actually the bigger challenge for us there. But I don't think on a case level, it's that big a deal, because they generally give us DNA levels. And if there's a flare, they're watching them, and they're trying to figure it out as they go as well. But along those lines of flares, I had a question for Nora, because I looked at the paper, and I was about ready to say, well, that's interferon combination therapy, where it's probably not going to go anywhere. But then at the end of your talk, you started saying about flares, on-treatment flares, being associated with surface antigen loss. Well, my question to you is, I assume those flares were on the PEG interferon arm. Is that true? Because usually that's where you see these flares. And does that leave the door open for, well, maybe you're not done? Is there a subgroup that would benefit from getting these flares from PEG interferon with a combination, and you might get or at least a better response? So that's my question, these on-treatment flares.
Well, the first thing is that we saw on-treatment affairs in both groups, right?
Okay.
We saw it with TDF as well. So you can get an on-treatment flare with TDF. There were less of those, and there were less moderate to severe flares, or, in terms of the severity, but we saw them with TDF as well.
Yeah.
So it's
So
not
it didn't
just,
matter.
but I think Jay made the point earlier, and I think it's well taken in that, don't forget that during that first, 24, 48 weeks when we're getting exposure to, and well, they're getting exposure during the first 24 weeks, but during that period is also when a lot of e antigen loss occurred as well, right? And whether it's only working in patients in terms of getting that e antigen seroconversion, and that the flares related to that are really these effective flares, I think is yet to be seen. But the fact that they happen in the TDF group also, and suggests to me that flares are telling us something, but it isn't only peg interferon that is the.
But the flares are definitely less
Yeah.
severe.
Yeah, for sure. Less severe and less
yeah.
often. So it does suggest it's doing, I think we all agree that it did something. It did something. We saw higher rates of e antigen loss. That's the most striking. It doubled the rate of e antigen loss, right? So it clearly had an effect. And then we know, of course, e antigen loss was also a marker for us in terms of getting S antigen loss. So, along that pathway, it seems like peg interferon has a role. And I think that that's maybe one of the important messages. It's the e antigen negative group, which has been the focus really for a lot of withdrawal studies, where here we didn't see that interferon was helpful. And withdrawal wasn't helpful either, actually.
Yeah.
You also need to point out that there were some people with e antigen who were withdrawn. And we rapidly learned that we mustn't do that, because the first two patients developed life-threatening flare with jaundice.
Yeah.
One was actually evaluated for transplant. Interestingly, he wasn't very symptomatic, despite a bilirubin of 17. What we didn't have in the HBRN, and as mentioned before, as a weakness, is we didn't have FibroScan, and it would be very important to know, after these flares, do people have kind of increased evidence of scarring and abnormality, stiffness to the liver?
Yeah.
Nora, I have just a brief comment. Do you think that it would be interesting to study the kinetics of, HBsAg, and see the difference during the flare that you have on treatment and the one soon after, when you do the withdrawal? Because it's very important. I think it's very interesting, the fact that you have two kinds of flare, but one is positive, one is negative. Are you planning to do some more virological study to see if you have any predictive factor in terms of virology or anything? Because that's very interesting.
Yeah, no, you make a good point. We've sort of separated them. We have two papers, right? One that's on treatment and one withdrawal. You're asking us to compare them. It's
I was just okay. And
that's a great idea.
Yeah, and if I can, I have just a little question and comment for William Lee, because about always the e antigen positive, e antigen negative disease, because I believe that there are two diseases. So usually, Will, in patients with acute hepatitis B that seek medical advice, the patients are e antigen positive. But in your case, you saw that nearly 30% of your patients were hospitalized in the very early phase, but e antigen negative. And the lack of e antigen was not due to a delay in the enrollment, at least according to the inclusion criteria. So we know that this is not a common finding in acute hepatitis B, but is frequently detected in fulminant hepatitis B, where patients seek medical advice, HBsAg antigen, sometimes, e antibody positive, e antigen negative. So my question for you is there was any difference in the severity of acute hepatitis B between patients presenting as e antigen positive and e antigen negative? Because it's pretty interesting, the fact that you have such high rate during the very early phase of infection.
Yes, I think we need to go back and look at that to see if there were any differences. On the face of it, there wasn't anything obvious that stood out. But I think perhaps you're right. We need to just separate out that E negative group and look at them as a separate entity. Were there any specific risk factor, or is there anything different about the E negative group from the E positive group?
Yeah, you should think that you should think of chronic disease if they're E antigen positive, E antigen negative to begin with.
E antigen negative,
But these
right?
didn't appear to be. It appeared to be early clearance of E.
Yeah.
which-
But still, is not a common finding because the clearance occurs always after. I mean, the flare of hepatitis. So it's still an interesting finding that they present.
But the
with
usual
actual
thing is that if you clear E antigen during acute hepatitis, you're going to recover. You're going to clear S.
Yeah, no, this for sure. They are all cleared about it. But I was just curious about the kinetic. If these are a different disease and is more severe than the class.
We should look at viral titers on admission and that sort of thing. I think that's
Exactly.
a great
Yeah.
point.
So this also points out the maddening complexity of the serology of hepatitis B. It's absolutely maddening. Hepatitis C is so much easier. There's just one thing to look at here. There's E, there's anti-E. And let me tell you, the other problem we had was we had two ways of measuring E. It was either measured locally, it was qualitative, it's either positive or negative. And we had a central lab that did it quantitatively. And unfortunately, there were differences. And we still haven't resolved them all, but there were some people who were positive by one and not by the other, and vice versa. And of course, the disappearance of E was very dependent upon the method, if it was one or the other. So it's this maddening complexity of the serology of hepatitis B that's so difficult. Right, Anna, you've had a long experience with this as well.
Well, I mean, hepatitis B, you're right, because we have so many different markers, and each marker can be measured using different ways. And some of these markers we used to just have qualitative tests, positive, negative. Then we, particularly for surface antigen, we now understand that quantification is important. Part of it is it may reflect your immune control, because antiviral and all that doesn't necessarily suppress your S antigen. So when the S antigen level goes down in untreated patients, it may be your immune response is better able to control the virus. And with all the interest in achieving S antigen loss, everyone is saying that low surface antigen is the best predictor. But that's like, okay, if I can't feel your pulse, I can predict you're going to have a cardiac arrest, because the surface antigen needs to keep going down to become undetectable. So in some ways is in the path of the surface antigen clearance. But I think that as we have more markers, some of the markers are going to be important for us to understand whether the cccDNA is less active or not. And we know that with the nukes, for example, TDF, you suppress the DNA, but the cccDNA is still there, it's still active. And that's when some of these new markers give us a better insight.
And the loss of S antigen, which we feel like is such a good endpoint, it's not always, doesn't always guarantee you that you won't develop a complication like HCC. I think what's important is cirrhosis. And as long as we see cirrhosis in patients with hepatitis B, our medical system has failed. We need to treat them before they get cirrhosis. Very important. And that goes to the issue of screening for surface antigen in the American population. Any proponents?
Well, I think the CDC is preparing to come up with this recommendation. I don't know when exactly it's going to come out. It's like Hep C, every adult, regardless of risk factors, get screened one time, because so many people don't recognize that they have risk factors. I mean, people have been exposed, people come from countries where hepatitis B is common. They don't remember that they have been exposed.
Right. Now, the trouble with hepatitis C, we have a cure, right? They have a good treatment. With hepatitis B, it's difficult, as you show. Some patients really don't need to be treated. And that's the difficulty. It's not as simple as hepatitis C.
Yeah,
I
this
think Will has his hand up.
Yeah, the
No.
I
CDC
think
is
it is
about to
important
come
to
out
know
with
that
their,
you're hepatitis B antigen positive as far as your family members and as far as follow-up is needed, even though you may not be able to be treated.
Jay, and the recent study also suggested that the major source of HBsAg is the integrated HPV DNA.
Yes.
So getting even more complicated, especially for endpoint of
Mm.
treatment. So I agree with you, very complex, the serology of HPV. It keeps us busy.
Yeah, I'll just make a comment that one, the CDC is, I'm on that panel of recommendations, and it looks like in the next couple of months, they're going to present their recommendations for universal screening for HBV to their organization, and they think the approval will actually come through in the fall. So by the fall, they will have made that. They've already made a recommendation for universal vaccination, and then they'll send that recommendation also to the U.S. Services Health Prevention group and get them to endorse it in addition. And then I agree with what Patrizia just said about HBsAg integration. I think those people are probably never going to clear surface antigen if they've got integrated HBsAg. And we've only got a couple studies that show that occurs, because the technique to show that currently is very, very difficult and very time consuming. So we need a better way to find that. And if we can find that out, then we can spare those patients with we can decide who we're going to treat with antiviral therapy and who not. And then the other problem that we have is, at least in Alaska, and I know in the US, is that with NAFLD coming along, about a third of our patients with chronic HBV have NAFLD, and many of them do not normalize their ALT, even though their HBV DNA goes below 1,000. So how do we account for NAFLD coexistence with HBsAg? And then the other problem, and I'm really glad that the network had used FibroScan, is how do we find the incidence of cirrhosis in patients with and predict cirrhosis in patients with chronic HBV, and the definition of what is cirrhosis without a liver biopsy. We need more data to come up with a better definition.
Well, everybody's trying. It's very difficult to get a complete assurance, and it's going to be a little bit different for each liver disease. It's quite complex, but FibroScan does make things easier. You can pick up cirrhosis in someone with normal enzymes, for instance, or at least a suspicion that they have cirrhosis.
Yeah, this Will. I was just going to ask the other clinicians if there's any criteria that you would use for withdrawal. Right now, my feeling is I'm not going to withdraw anybody based on our study. Nora?
Well, I think there's some I think Anna highlighted that, of course, the thing that predicts your ability to be withdrawn is having a very low surface antigen. So if I have a patient who has got a surface antigen level under 100, I would certainly talk about it. You have to have an adherent patient. They have to be motivated. So I would consider it in that patient with close follow-up. And then I think the additional data from our study, where a rise in HBV DNA is really telling you that the patient is not only not going to clear surface antigen, but they could have an ALT flare, has helped me, because I'm going to use that as a tool to say, okay, you're going to go back on treatment. So I would do it in a very, very select number of patients. Fortunately, we have surface antigen quantitation available to us, and that is a new tool, I think, for us to try to think about stratification. And in my practice, the number that have a surface antigen level under 100 is quite low. So it's not a lot of patients who qualify.
But the question is whether you're stopping therapy because the patient doesn't want to pay for it or just tired of it and so forth, versus trying to clear S. And I think the answer here is don't stop it in the hopes that it's going to help you clear S. But some people don't need to be on it. In fact, some people may have been put on it inappropriately. We found that out several times. We've taken people off therapy who clearly didn't have criteria for treatment, and they did fine. So some people can tolerate stopping therapy, and we need to look more closely at our data, in fact, and it's still being looked at, still being analyzed, can we predict who will tolerate being off treatment, basically?
Right.
Yeah, I
I mean,
completely agree
Most
with
of these
Nora.
flares were asymptomatic. Most of them were asymptomatic.
Yeah, I completely agree with Nora. I don't take patients off treatment because I'm doing it to increase the rate of S antigen loss. It's usually the patients come to me and say, I've been on treatment for so many years. I don't really want to continue treatment any longer. And in the older patients, I would usually say, no, it's very high risk because the chance of having flares and decompensation is much higher in the older patients. In the younger patients, if they ask and they ask again, and I said it's okay, let's just order quantitative S. If it's still very high, it's just not going to happen. You're going to just have recurrence and put back on treatment in a year or two. But if they have low S antigen, which like Nora, my experience is very rare, that I find someone who's really got a low enough surface antigen, then I'll say, okay, if you agree, monthly labs, so I keep an eye on you. And I also agree with Nora. In the past, we sort of wait until the ALT goes up. And we find that when we wait for the ALT to go up, it may be late. We should, as soon as we see the virus DNA keep going up, even if the ALT is normal, that's the time to put a patient back on treatment.
Right.
Yeah,
I have another question here from the audience, and it has to do with the acute hepatitis case with genotype A2. Are these patients the ones who have delayed recovery, or what can you say about that?
No, I don't think so. I think we need to go back and look at it one more time, but I'm not aware that the A2s were the delayed recovery patients.
But you know, the fact that in Asia, hepatitis B is common chronically, whereas in Europe, it usually was not chronic. Could that have been a genotype difference? That in Europe, the common genotype was A2, and so most people recovered.
Yeah, also the genotype D is pretty predominant in Italy and in Eastern Europe, and we found that the outcome in those patients with including HEC and including cirrhosis is quite a bit lower than in genotype C in Alaska Native population.
Right.
The other thing to point out is
in hepatitis B.
I was just going to say, the other thing to point out is that I've had several who become S antigen negative, let's say after I've been caring for them for a number of years, but they still have occult HBV DNA. They still have 500 IU or 300 IU. And that's another quandary. If they have cirrhosis, I certainly would keep them on treatment, even if they're S antigen negative, I guess, if they have a viral load return. But some of them will just ride along with a viral load of 500 IU for a long time, S antigen negative, not on treatment.
I found that they eventually will go away, but maybe not. Just too few. Nora, do you want to address those issues?
I have a very low number of such patients, but I've seen them as well. I agree with you 100%. If they have advanced fibrosis, they're on treatment. I think virus is just not a good thing for those patients, so I would treat.
Even if they clear surface antigen?
Even if they've cleared surface antigen. If they've got persistent viremia that I'm detecting at low level, I would treat that. Yes.
So in the HBRN, there was one person who cleared surface antigen who had cirrhosis and was not withdrawn. So you would leave that patient on?
I would. I think, I feel like if the virus there is still probably driving some risk, whether it, especially for HCC would be my concern. So I would suppress that patient.
Well, I would, if you wanted to take them off, I would be very careful.
Yeah. I think that's very true.
One thing about the HBRN, they did a great job of following this withdrawn patients being seen every month. I don't think there was a single patient we lost.
Yeah, it points toward
they were off
dedication.
therapy.
Yeah.
Hard work.
So any other comments? Have we run out of time? Almost.
I just want to highlight one thing that Bob Perillo, so thanks, Bob, for chiming in here. So Bob Perillo is the lead on the paper related to the ALT flares during treatment. And he had a comment to the chat that said that and this is something where he's got the details. He said they looked at the flares by e antigen status, and it didn't always correlate, didn't find that was an association, that the ALT flares were related to the e antigen loss. So implying that there's sort of more to it in terms of the flare. I'm going to just read.
It's the drop of surface antigen with e antigen loss. You see, that's why it's confounded.
There was not. It's difficult, to tease out these things. I think
with the PEG interferon treatment, the loss of E and S occurred together within a month or two of each other. So you couldn't kind of separate out whether it was the clearance of S or the clearance of E. It's very complex, like everything in hepatitis B.